All right, let's talk dental implant placement techniques. This is a common scenario we have. We're working in the mandible. A patient has been missing a lower molar for years. Typically this would be the grandma patient who, for whatever reason, decides they want to replace this molar. We're going to go in and try to place this. But let's talk about what the complications or difficulties are here. We've got a mandible, which we know is going to have a cortical plate of about 2 millimeters that is very dense, but also very avascular. And then within that, typically what we'll see is a marrow space that's very osteoporotic. It's got very soft, kind of mushy bone. And the challenge here is, if we go to place an implant, where do we get primary stability? If we try to use this hard cortical bone and we say, okay, well, the bone in here is soft, I'm just going to drill my normal osteotomy, and then I'll place my implant, which we know the implant is slightly larger, and that's how we get our primary stability, is it crushes the bone on either side just slightly. So we do that, but the soft bone, we hardly are getting any stability or torque here, and we're getting all of our pressure right on this cortical bone. Now, what makes this even worse is the fact that this bone is very avascular, the hard cortical bone. So what we'll end up with is bone dieback as it heals, because there's no blood supply to this bone, and we'll lose bone and get cratering around that implant, or exposed implant as it heals. So what do we do to avoid that? What we want to do is use the situation to our advantage. So instead, we'll drill a small hole with our pilot, and depending on the density of the bone, maybe we go a little larger but still undersized, and then we'll take a countersink and go to true size through just the bone here. So we cut away the cortical bone, but we leave this area grossly undersized. And what that's going to do is, when we place our same implant down into this, we'll get a lot of compression in the soft bone, which will allow us to gain our primary stability down below where pressure necrosis isn't an issue. And then here, we haven't crushed the bone, and sometimes we even leave just a little bit of space for that blood to wick up, so the implant heals to the crest without bone dieback or other issues.